Good morning, everyone, and thank you very much, Alison. Welcome to Sheffield. Welcome to this magnificent hall, Cutler's Hall. Sheffield was famous for steel, and the fine piece of steel you can make is cutlery, and this is really sort of how this hall really was built, and more probably to come from John, who really knows about the history more than I. But thank you very much. I think I'll set the scene in relation to StarMS. John will talk about it later on. I don't really have a lot of conflict of interest. But I didn't really know a lot about stem cell transplantation until I met this man. And he talked to me about it, and my jaw dropped. But the first two patients that we've treated a long time ago now were Sam, who was really a young girl who was quite healthy, and she was struck by MS, and she ended up in ITU. And all the drug that we used at that time failed, and stem cell transplantation saved her life. And the other person is Holly, who was again somebody who has MS, failed to respond to all the therapy that we had for MS at the time, and ended up having stem cell transplantation with excellent results. And this is her first daughter after the transplant. So our first paper was not published in a medical journal. It was published on Mail Online. And then the BBC knew about what we're doing, and they came, as you probably all know, and really filmed us doing our work for about 3 months, and then produced this panorama program. And that, I thought, really sort of made a shift in terms of the attitude towards stem cell transplantation in the UK, and helped really enormously in the UK as such. But really, this really procedure is not new. It's been around for a long period of time, probably for the last 3 decades. And it started, many of the slides that I'm going to talk about, and perhaps later on others, will refer to work done by Richard Burt, but started with animal models in relation to the use of stem cell transplantation, which really sort of set the scene. But the first patients who really treated with stem cell transplantation for autoimmune conditions were really treated because they had other pathologies which required stem cell transplantation, but at the same time they had autoimmune conditions which really responded after the treatment to that particular line of therapy. So here's a case that John wrote up, a young child who had aplastic anemia, which required stem cell transplantation, but at the same time he had rheumatoid arthritis, which really sort of settled down after the treatment, showing that this is a very good line of therapy for autoimmune conditions. The first 2 patients with MS treated with stem cell transplantation came from Chicago, from Richard Burt again, and from Greece. And then it was thought really soon afterwards that this treatment going to take off very rapidly. So the European Bone Marrow Transplantation Autoimmune Working Party devised a database so that all the cases can be collected, and so that knowledge can be accumulated in a systematic manner. And then it was recognized that guidelines really are needed. So the first set of guidelines were really produced in 1997. Because this is really a complicated way of treatment, need to be monitored and regulated, and all the centers who provide the treatment are really certainly regulated by the HTA, and JC really sort of inspect all the sites and approve really them before they are able to reduce the treatment. And then the first set of neurology-specific guidelines, autoimmune guidelines, were produced by, again, John and others from the ABN back in 2021. But really, there were no clinical trials at that time, and all the data which were acquired came from large cohort of outpatient treated in specialized centers. So this is one of the largest cohorts at that time, from Sweden, from Uppsala, where about 50 patients with mainly relapsing remitting multiple sclerosis were treated. And you could see really that the treatment is quite effective. Treatment-related mortality was 0. And the patient really responded magnificently to this treatment, but you can see really that those who had active disease, as evident by the presence of GAD on their MRI scans, or those patients who had were not very disabled, and those patients who had an illness which is not, the duration of the illness being not too long, did better than the other patients. And then the second largest cohort of patients came again from Chicago, where 151 patients, mainly with relapsing remitting, were treated. Those patients had failed various therapies. And again, the response was really astonishing. For the first time, Richard Burt showed that those patients who were treated, their level of disability dropped from 4.2 to 3.2 by 1 point, which is really sort of unheard of in multiple sclerosis. But what was needed really is a clinical trial to confirm all of that, and there isn't really a lot of trials, and this is the first phase 2 study, which came from Italy, where patients with mainly progressive disease were randomized to receive either mitoxantrone, treatment that we don't use much these days, or stem cell transplantation. The cohort was quite small, 21, but again you can see that those patients receiving the treatment did better by judging by MRI scan disease activity. So what was required then is a phase 3 study where the patient would be randomized into either stem cell transplantation or standard disease-modifying treatment. And again, Richard Burt came to save the day by launching this study, which we're really quite lucky to take part in. But the study was coordinated and run in Chicago, but also sites in Uppsala in Sweden, Sheffield in the UK, and Sao Paulo in Brazil. And that study really sort of recruited patients who have relapsing remitting multiple sclerosis, failing disease-modifying treatment, into either stem cell transplantation or the best available disease-modifying therapy at the time. Now, this study was a long time ago, so drugs like ocrelizumab, ofatumumab, cladribine, and probably alemtuzumab, Lamtrada, were not available at that time. Lamtrada became available towards the end of the study. But 110 patients were randomized into either stem cell transplantation or the best available therapy. So patients who were really, say, on interferon could have been randomized into something stronger. Natalizumab tisagenlecleucel was part of the study, and the outcome measure was disability progression after treatment. And again, the results were quite astonishing, really. So you could see that only 3 patients in the transplant arm got worse compared to 34 out of 55 in those patients who received standard disease-modifying therapy. And again, the level of progression of disability got better, i.e. patients became less disabled after receiving stem cell transplantation, whereas the level of disability continued to progress after receiving standard disease-modifying treatment. So that was a game changer. And then following that, the neurology-specific EBMT guidelines were published. And for the first time, we indicated that those patients who have highly active relapsing remitting multiple sclerosis should be offered stem cell transplantation as a standard of care. But the guidelines also suggested that those patients who have inflammatory progressive disease should be offered the treatment as a treatment option. Also, those patients who are treatment naive but have active disease should be offered the treatment as a treatment option as well. The UK, being the UK, here is the EBN guidelines, did not really follow suit, and they suggested that stem cell transplantation can only be offered after all other therapies have failed. The ABN guidelines have really changed of late, but not really greatly. But you can see that the autologous hematopoietic stem cell transplantation is on the bottom of all the treatment choices. Europeans were a little bit more proactive in terms of how patients should be treated, and So ECTRIMS and the European Academy of Neurology suggested that those patients who have active disease should be offered highly efficacious therapies really from as early as possible to prevent the occurrence and the progression of disability. And also found that those patients who have really active disease, if they receive stem cell transplantation quite early as the first line of treatment, they do extremely well. Here's a group of 20 patients who were collected really from various sites, including the UK and North America and Europe. And those patients had really aggressive disease, and they were treated with stem cell transplantation. And you can see that the level of disability improved markedly, and then after the treatment, they remained stable. So did not really have any MRI scan or evidence of disease activity thereafter, as if really they're being cured from multiple sclerosis. But what was needed then is a proof that stem cell transplantation is equivalent or better in terms of efficacy compared with the disease-modifying therapy that we have these days, including Ocrevus and Kesimpta and the other highly efficacious therapies. So there are now at least 3 studies trying to answer this particular question. One in the United States called BEAT-MS, one in Scandinavia called RIME-MS, which is almost really so fully recruited, and StarMS, which we run in the UK, and John will talk about that in a second. So there remains really sort of uncertainty about the role of stem cell transplantation in the treatment of patients with multiple sclerosis, both relapsing and progressive disease, which is really sort of been highlighted in this really easily read article in the BMJ, and I would encourage you to have a look at that really if you want. And we hope very much that StarMS and the other studies will address that, and we hope that we'll build on this in terms of also running studies for patients with progressive disease as well. This is what we do in Sheffield. Welcome to Sheffield. So we really, our policy is that we treat patients with inflammatory disease who failed disease-modifying therapies. We really offer the patients treatment on trial if we have a trial suitable to them. But we also offer them the treatment on compassionate basis based on the international guidelines. And we truly really treat them in a multidisciplinary unit. I'm very lucky to work with John. We both really work in the same building, and we have offices near each other. We see the patients together really from the beginning of their journey towards the end. And I just want to thank everyone who helped us really with this journey, particularly AIMS, who really helping us enormously in terms of encouraging patients to join the study. So I will leave the platform now to John.